So on a Sunday morning, we have turned on our web scan for this wonderful event on vitamin D symposium. So why vitamin D is such an important aspect in today's life? Even after going out in the sun, I hope everyone is having their normal vitamin D routine on Sunday morning, having a good run of this thing 15-20 minutes in the ground or something. But even after having these things, why are Indians are facing such a high amount of vitamin D deficiency? 3 out of 4 Indians are having this vitamin D deficiency. This is a concern. And talking about how to get to that vitamin D sufficiency, or we can say the 30 nanogram per ml, which is in ideally recommended. So even the conventional formulations doesn't give to or give rise to that levels. And today we have our esteemed guest with us. So who would be taking us through this, how we can get to that levels and why getting to that levels is very important for maintaining the physiological benefits. So with this, I would like to have a few slides for a formal introduction on the speakers and a formal introduction of Pulse Pharmaceuticals, who is organizing this wonderful event. So before starting the PPT, I would like to run a small video of Pulse Pharmaceuticals for the introduction part. So I would request for the video.
Pulse, a true reflection of the heart and its functioning. A heart that is compassionate about others and passionate about its work. A heart that is dynamic yet consistent. A heart that is predictable and reliable. A heart that goes the extra mile to deliver what is expected. Our business philosophy encompasses these very principles. At Pulse Pharma, we feel patients' problems, think, innovate, and do everything that it takes to deliver cost-effective solutions. We have a well-aligned leadership team and a highly motivated functional team to carry out our mission. We innovate and develop products with unique functional characteristics that help us serve our customers' needs better. We develop innovative business processes that help us improve our efficiency and customer experience. We have world-class infrastructure that includes an integrated R&D center and 3 manufacturing facilities that help us develop and manufacture high-quality differentiated products. Our research efforts are focused on developing nanotherapeutics, nutri-therapeutics, and cell therapeutics. Our operational presence is spread across India and 40 countries worldwide. We reach out to nearly 250,000 healthcare professionals in various specialties through our sales team of over 1,000 people and our partner sales force in various countries. At Pulse, we work with a real spirit of Pulse to bring about a positive difference in millions of lives. Because we are compassionate about people and passionate about our work.
Thank you for the video. Now I would like to have a formal introduction. So So I invite you again for this wonderful vitamin D symposium with right vitamin D for better patient outcome. So we have our speakers here, Dr. Debasis Basu, Dr. Mary DCruz, and Dr. Mukhopadhyay. With this, I would like to have a few words about my company, Pulse Pharmaceuticals, who is currently organizing this symposium. So what to speak about Pulse Pharmaceuticals. So Pulse Pharmaceuticals is a very patient-centric, innovation-driven pharmaceutical company with an integrated growth model. We have completed 26 years in this pharmaceutical field, and we are running into 27 years of working into pharma sectors. We have a world-class R&D and manufacturing infrastructure spread across India. We have a very strong leadership and operational teams which functions across all business models. We are leading the space of nanopharmaceuticals through our novel drug delivery research. So one of our patented technology, nanotechnology, with our patented brand, the Deksel. We have a strong presence in medical nutrition through Pulse NutriScience, and we are also getting into CAR T cell therapies for the onco segment. So we are also going into protein segments and also in the onco segment. Speaking about the business philosophy, we have a very clear business philosophy. We create customer value through high quality differentiated products and services using advanced and patented technologies, as nanotechnology I just spoke about, which the marketed product is Deksel. Regarding the infrastructure, we have quite a large number of infrastructure, quite a large manufacturing facilities across India, right from Hyderabad to Roorkee. We have our own advanced research center in Hyderabad, and we also have a Pulse NutriScience R&D and manufacturing facility which is located in Genome Valley. We also have an R&D facility that is under construction at Hyderabad only. So that's about infrastructure. Regarding the awards, we have got quite a few awards for our contribution in pharma sectors, like Udyoga Bharati Award in 2006. In 2010, we have been awarded with Hall of Fame Award, followed up by National Award for Quality Excellence in 2011, and also a very important award in 2018 by NDTV as India's small national giant. With this, I would like to welcome our first speaker, the chairperson for this meeting, Dr. Debashish Basu. For Debashish Basu, I think most of the physicians across the country knows him very well. But for a formal introduction, I would like to have a few words on him. Just a second. So, speaking about Dr. Debashish Basu, so he's a chairman of Meta Foundation, who is self-initiated from foundation of him, followed up by a medical director of Helios Global Private Limited. He's also a senior consultant in diabetes and prevention cardiology in Apollo Hospital. He is also a former in charge and founder of Sugar Clinic in Apollo Hospital. As a professor, he's serving as a professor in internal medicine in Bengal University. He is also a chairman of stem cell therapeutics in IIT Kharagpur. Then he is an Indian expert in FID. He's also an external examiner or reviewer for PhD in Kolkata and as well as in Pune University. He is also serving as a principal investigator for many phase 3 clinical trials, and also as an author and co-author in many publications which are associated with national and international journals with high impact factor and PubMed index. So with this, I would like to welcome Dr. Debashish Basu. Hello, sir.
Hello. Thank you for that. Those really kind words.
Yeah.
We are actually starting, I think, a big chapter.
Just a second, sir. I would introduce the other two speakers as well, and then we can start.
Fine.
Okay. So speaking about the other speaker, Dr. Mary DCruz, again a very well-known physician in Kolkata. So speaking about Dr. Mary DCruz, she has done his MD in internal medicine, and now she is consultant physician and diabetologist. She is a past president Diabetes Research and Welfare Association, vice president of DAY, which is Diabetes Awareness and You. She has also been an ex-president in API West Bengal chapter, an executive committee member of API, a certified physician by DJ Shimping, Government of India. She's a lead auditor in ISO system. So community mental health diploma from NIM HANS Bangalore, and also a faculty in enhanced postgraduate certified in diabetes. So with this, I would also welcome Dr. Mary DCruz.
Thank you for your kind introduction.
So the other speaker, Dr. Monojit Mukhopadhyay, a very senior consultant diabetologist and endocrinologist. He is currently practicing as a consultant endocrinologist at AMRI Hospital and EDDF Hospital, Kolkata. He is also a faculty at various national and international forums, a very avid researcher and involved in a number of phase 3 and phase 4 clinical trials. Also a faculty at a prestigious IDF certified course run by PHFI to train physicians on diabetes in India. Author and co-author in many chapters and books for diabetes across physician and patient forum. And he has also been invited as a speaker for poster presentation in EDA in 2019. So he has represented EDA in 2019 as a speaker. So with this, I would also would like to welcome Dr. Monojit onto the stage.
Thank you. Good morning, everyone, and thank you for the kind introduction.
So with this, I would like to say a thank you from my side for this formal introduction. Just to have a special mention, we also have Mr. Samar Ghosh from Pulse Pharmaceuticals, who will be talking a little about the science of Pulse Pharmaceuticals and why this company has been serving for 26 years in the field of nanoscience, and what is the patented actual nanotechnology, and what is Nanocarrier vitamin D3. So he would be speaking a little bit about this thing. He's currently working as a president in Pulse Pharmaceuticals for sales and marketing. So Mr. Samar Ghosh, I would also like to welcome you onto the stage. With this, I would like to hand over to the speakers to take us forward on this wonderful symposium.
Dr. Harsh would not be there. Okay. So may I have the privilege to start the morning session? It's a privilege. It's a privilege to talk on the subject, which is not really it's been talked about, but not really been discussed well so far. As three doctors, and I would say three idiots, but I would quote three idiots and say, give me some sunshine, but give me some rain as well. If you come to Kolkata, you'll feel like it's 43, no? It feels 43. Give me another chance, and I want to grow up again, once again, with vitamin D. Now, vitamin D deficiency is a major public health problem worldwide in all age groups, even those residing in countries like low at latitude like India. We have understood that whether you are an industrialized nation or you are always a developing nation like us, you are actually living in a vitamin D deficient state. There are a lot of data coming in, but the overall data that is lacking is how we guide ourselves and our patients to have a formidable vitamin D level so that the best of health can be achieved. I would beg to differ from the routine habit of prescribing 800 to 1000 to 2000 international units a day. I have been practicing with vitamin D since 2011. That was the first time I started vitamin D in assay in Apollo. It was very costly, and thereafter we do vitamin D, B12, and iron profile to all our metabolic cases. Now, I would like to say that it now appears that it is maybe it is 8,000 international units a day for people like all of us, especially now when we are even hating to look at the sun. So maybe those governments were way off that factor by the magnitude of 10 error, and this scale of mistake has never been recorded in history. So I think there can be time for puja, for Diwali, for flu, for cold, even for COVID, but there is a perpetual vitamin D deficiency season for all of us. So we must wake up and address the problem with its might. Now, can I have the first slide?
Dr. Debashi, sorry to interrupt, but the voice is a little slow. So it would be great if you can just increase the volume.
Volume.
I think your voice just.
Can you now hear me?
Yeah,
Can you
yeah.
go back
Now
to
it
the
is
previous slide? Not this slide, the previous slide.
just a second, just a second.
The second slide.
Yeah. Over to you, sir.
Yeah, yeah, thank you. So vitamin D is obviously labeled as a sunshine vitamin, and it is produced in the skin during the sun exposure. Vitamin D is also, it becomes a hormone, and when it comes out of the kidney in that form of calcitriol, it becomes a hormone because it produces action all throughout the body from top to toe. Ultraviolet B, that radiation for that wavelength, is very important for that conversion of 7 dihydroxy, dihydrocholesterol to make it to vitamin D. Now we all know about this, chart and the timeline and the progression. Can I go to the next slide, which clearly tells us? Yeah, yeah. So this is how it is activated by the action of 25 hydroxylase in the liver, and then the 1 alpha hydroxylase in the kidney. That's the final end product which works. And it actually then goes inside the cell. And this is a mechanism of nuclear activation where it sits beside the retinoid X receptor and starts the whole, the magic, the miracle that happens. The intermediate metabolites all start secreting, and then we get the all, as I say, from top to toe, all the good benefits of it. Next slide. This is a wonderful slide. Now, this slide is talking about the pleiotropic actions of vitamin D. Previously, when vitamin D was identified and discovered, we used to talk about, rickets, osteomalacia, not osteoporosis directly, but rickets and osteomalacia, things with pain. Then we started talking about the extra skeletal part of it. And there we understood that this whole RXR and vitamin D, the expression on the gene, actually takes a major role to play because all the cells, mostly all the cells, have this vitamin D receptor. And therefore, this slide clearly tells us that apart from bone, it's the immunity, it's a cardiovascular disease system, the endothelial progenitor system, the cancer, type 2 diabetes, neuroprotection, everything is involved here, with the effect of vitamin D. I would also briefly harp upon even hypertension. Hypertension, the way it happens is it regulates vitamin D, the alpha 125 dihydroxy vitamin D. It inhibits the production of renin in the kidney and the heart, as well as also prevents the ANF from the heart. So thereby, the vascular constrictor system is off. It is dilator system, no aldosterone, less aldosterone, and less of hypertension. For diabetes, commonly we see the regulation of insulin secretion and the peripheral action, both insulin secretory pathway, insulin sensitivity pathway, 125 hydroxy dihydroxy vitamin D, along with calcium that promotes the secretion of insulin and stimulation of glucose by the peripheral tissues. So very important, to hypertension and diabetes and vitamin D I covered. Next slide. Yes. Now, this is a next. This is a from a paper which came out that said that almost 75% people, I mean, like the US as they claim, they suffer from vitamin D deficiency. We had a meta-analysis published by Kalra et al., which said that almost 67-70% of them in Bangladesh and Indian population, they suffer from vitamin D deficiency. I talk about Bangladesh because the three of us also keep seeing Bangladeshi people. There is a one, kind of a revelation, and I would say a revolution should happen on this data. Recent reports are saying that there is a high prevalence of vitamin D deficiency to the tune of 96% in pregnant and lactating women and 99% in infants. So can you understand the role of the community now here? Next slide. So yeah, now you see the multiple number of myriad of papers showing that the mean vitamin D level is actually less than 20, right? So it's pretty less. And then next slide. Yeah, now these are all the guidelines all across the globe. These are the guidelines which say that, randomly, when you look at the columns, you will find the deficiency is, somebody says it's less than 25, some says it's less than 30. Endocrine Society practice guideline says it's less than 50, all in nanomoles. Insufficiency is 30 to 50 for IOM, Institute of Medicine. Endocrinology Society practice guidelines say 50 to 75. We will not bore you with this because we have our own RSSDI or ESI, Endocrine Society India data as well. Next slide. Next slide. Okay, so this is again from Kalra's paper. It'll be very nice and wise to go back and read this vitamin D in clinical practice, the current perspective. It is published in the IJCP, where it says that the individuals who are asymptomatic can be given up to 2,000 international units per day, symptomatic vitamin D deficient. Now, what do you mean by that? So I think you must refer to the paper. It's quite a detailed discussion on that. 60,000 international units. Even if you have diabetes, you have symptomatic vitamin D insufficient. There you initiate 60,000 once a week for eight weeks. If unsatisfactory, then once again continue, and then maintenance once a month. Now, this can all be, these are guidelines, but according to your customized practice, for me, what I do, let me tell you here, once I have the privilege, I do once in 8 days as of now for routine practice, for 2 months, then one in 10 or 14 days, depending on the next value, to continue for life. As I said, we are in a vitamin D deficient state all across seasons, across the world, for maybe time to come, till we don't get an answer. And symptomatic vitamin D deficient, it will be obviously higher. They initiate with 12 weeks, 3 months. You can do it even 6 months, because we have a lot of data, with pulse therapy, etc. We finally know that there's this toxicity of vitamin D is almost a misnomer, if not a myth. Next slide, please. This is.
So, having heard all that about vitamin D deficiency, the current regime for the treatment of vitamin D, either insufficiency or deficiency, does not take into account the physiological factors of individuals. And we get patients of all kinds, particularly now with the obesity epidemic. We have patients who are elderly, we have patients with metabolic disorders, diabetes, malabsorption syndromes, and also hepatic insufficiency and renal disease. So, no patient comes with just one complaint. And the commonest complaint, like Dr. Debashish said, regarding vitamin D deficiency could be ranging from just fatigue, tiredness, exhaustion, and then again, you have bone pains, muscle weakness, loss of appetite, loss of hair. These are the commonest complaints and range through all these problems that I have just mentioned. So, while obese and overweight patients would probably need 2 to 3 times the dose of vitamin D as compared to a normal individual. So, rightly said, even I now give them doses that are maybe 60,000. Sometimes I had a lady the other day who had just 3 nanograms per ml. And she had just tiredness and weakness. That's all, not no other complaint. So I have stepped up actually by giving her 60,000 on an alternate day and come back with her results, after which I shall decide whether I'm going to give her 60,000 twice in a month. That's once in 15 days. So, considering all these, though the guidelines and regimes exist, we need to know there are patients who have a deficiency and require higher doses. Next slide.
Okay, next slide, please. Good morning, Dr. Monojit Mukhopadhyay here. So let me take you back to your school days. Okay, I'm sure you've heard about Sir Isaac Newton, and in physics, you learned about the third law of motion. That is, for every action in nature, there's an equal and opposite reaction. Now, what does that mean when it comes to vitamin D? So, for every level of vitamin D, there's an equal pharmacodynamic. So, we don't go by, when you're happy to get your patient levels up to 30, we need to step it up, and we will see in the subsequent slides how a gradual increment in your vitamin D levels will give you an increasing benefit. So, for every vitamin D level, there's an equal pharmacodynamic effect. So, over to Dr. Debashish Basu again, please. Next slide, please. Yeah. Next slide, please. Yeah.
Yeah, Dr. Devashish, sorry to interrupt again, but the voice is quite low. So I would request if the
Achha.
voice can be.
Can you hear me now?
Yeah, it is now it is now quite manageable.
Okay. You couldn't hear Dr. Mukhopadhyay speaking?
Dr. Mukhopadhyay was quite audible, but you were not.
Okay. Well, this is a very interesting slide, and we have been really talking about vitamin D, uh, with a lot of gusto during the COVID times. And why was it so? Because meta-analysis kept on telling us that vitamin D level less than 50 nanomole had almost a 65-70% increased risk of community-acquired pneumonia. This we got to know the data.
Dr. Debasis, we have lost you.
Can you hear me?
Hello. Yeah, sir. We have actually lost you in between. So I would request you can restart.
Okay. So basically, COVID-19 and vitamin D, I was just doing a little bit of preview saying that before that already we knew that less than 50 nanomole per liter can give you an increased risk of around 65% more of community acquired pneumonia. Now, having said that, naturally, COVID-19 is pneumonia. I mean, we don't ever go to the viral segment of it, viral replication segment of it, but ultimately it's pneumonia. So naturally, it would have occurred in people with low vitamin D. And we also now know vitamin D deficiency, it overactivates the RAS system. And if you have that deficiency, then that will overactivate the RAS system, and it will also aggravate the extracellular matrix. So whatever matrix you have in the alveolar basement lining, they become fibrotic. And so we all saw the capillary thrombosis, the fibrosis happening, that ground glass. Maybe that vitamin D deficiency definitely must have contributed to that. Now, what I'm saying is, why will you give vitamin D? In this case, we also heard that DPP4, that CD26 subset, that had a very important action here. That exhibited to connect that S1 domain of the COVID-19 spike glycoprotein, so which is a very salient virulence factor for COVID-19. The expression of DPP4, therefore, was reduced significantly with the correctness of vitamin D, and thereby the whole activity of the glycoprotein went down. So there we are now particularly sure about, from all these pathways, that the vitamin D was important. But how much was it important still remains a question. How much to actually reduce the IL-6, to delay the interferon gamma, all these factors needs to be decided. Next thing.
So yes, there have been vitamin D unpredictable results in COVID-19, even though we know that there is a reduction in the pro-inflammatory factors. The study in 2021 by Lucky Reddy M.
Hello. We have lost you again. Hello.
Okay.
Hello.
Hello, can you hear me?
Yeah, ma'am. Actually, you were lost in between. So I
Okay, I'll
think,
begin from the beginning.
okay. Okay.
So vitamin D, like Dr. Basu said, has got unpredictable results in COVID. There's a study in 2021 by Lucky Reddy M. et al., which showed that vitamin D supplementation leads to a significant reduction in inflammatory parameters that were highly elevated in COVID-19 infection. However, one study done by Bugarin J. et al. Concluded that vitamin D supplementation does not lead to any significant reduction in inflammatory parameters that were elevated due to COVID-19 infection. Similarly, another study by Rastogi et al. Concluded that vitamin D supplementation leads to only a significant reduction in fibrinogen levels, but it doesn't lead to any significant reduction in any other parameters. So why is this difference with vitamin D supplementation? Is it the dose? Is it the manner in which it is given, either in the form of powders or capsules, or what is it? Next slide, please.
Yeah. So that is that's quite a poignant question poised at us. Now, very clearly, look at this slide. It gives us a very clear data saying that Lucky Reddy was success was with the post vitamin D levels. It was around 90. Because he found SRS actually negative RNA. His fibrinogen levels came down. So he was more than 50. And Rastagi, Anil Bhansali, they were all together in this study. And they were very happy. They were actually very happy. And I would add a little bit here saying that there was a study following this where they showed, yeah. So where they showed that there are levels, there are blood transcripts from levels of, functional element of that they call fall R3. Now, fall R3 are, certain parameters which only express, they're upregulated with COVID. When they were given different doses of vitamin D, that fall R3 fell down. And that clearly showed that a long-term vitamin D supplementation for deficient and insufficient adults could potentially actually reduce the risk of developing severe COVID-19 through a mechanism. It was developing, people started putting in a lot of vitamin D at home. I mean, a local kind of a practice came in the households, and maybe that had an expression in the gene.
So your connection, I think you are having some network issue. You are joining and rejoining then. Hello, Dr. Basu, can you hear me?
Control.
Yeah, Dr. Basu, can you hear me now?
Yeah, I can hear you.
Yeah, we have lost you in between.
Now,
So
where did you lose?
I think from the point of levels.
So levels, okay. So I mean, that final question where we were poised at, we stuck at why there were kind of mixed results. Why Lucky succeeded? Why Bugarin failed? Why Rastogi, did moderately all right? Because clearly we see Lucky Reddy's the post vitamin D levels were 90, Bugarin's were 23, which is almost equivalent to the normal standard general population. So it did not bother to have any impact, no significant reduction in CRP or anything. Rastogi had a very good finding. Rastogi had of not only fibrinogen changes, his SRS, the RNA were all negative for all the cases. He applied vitamin D. And thereafter, I was just elaborating on, one gene expression, how vitamin D actually helped to reverse the gene expression, which was upregulated during COVID-19 times, but vitamin D downregulated that fall R3 gene expression. Next.
Oh, can we move to the next slide, please? Yeah. So I'm more back to my familiar territory. I'm a diabetologist. So here I look at the importance of levels in pre-diabetes management. Nowadays we're trying.
Sir, sorry to interrupt. Can you please raise a little voice, a
Okay.
little louder, a
So
little
we are
decibel?
trying to prevent type 2 diabetes at the pre-diabetic level. So that is what we are doing. We are using, weight loss management and other methods and some medication. So here we will look at how vitamin D levels can be important in your levels in managing a patient with pre-diabetes. So this is a paper from 2023. These are very recent papers, level 1 evidence. They looked at vitamin D and the risk of type 2 diabetes in people with pre-diabetes. It was systematic review and meta-analysis of individual data from 3 randomized clinical trials. And what they found out that individuals who maintained a mean 25 hydroxy vitamin D level or at least 50 nanomole. Okay, so all this time we were talking about more than 20 and 30. Now you can see we've gone up to 50. So more than 50 nanomoles per mil had a 76, whopping. You can see a very high, impressive figure of 76% lower risk of developing diabetes compared to those with a level between 20 to 29. So a vitamin D deficiency definitely gives your patient a risk of converting from pre-diabetes to diabetes, and that is what is I aim. You are nine. Okay. Can we go move to the next
Uh,
slide, please?
Dr. Mukhopadhyay, we have lost you in between.
Yeah, yeah. No, I finished the this slide. Let's move to the
Okay,
next one.
no problem. Just a second.
Yeah. Okay. So, what is the importance of vitamin D levels in diabetes management?
Sir, can you please increase some of the decibels, because I think it is quite manageable, but it would be better if you can just increase it.
Increase. I'm talking very loud. No, I'm very loud. So most of the studies on vitamin D in diabetes showed an improved glycemic effect on vitamin D supplementation. You can see different papers, okay? And you can see over here, let's look at the post vitamin D levels. In the first paper, 40 nanomole per ml. And the difference in the HbA1c compared to baseline was zero point 0.4. So just getting your patients into that. Yeah.
So we have lost you,
Yeah,
Dr. Mukhopadhyay.
Yeah.
we see that. On our console, we don't see the projection.
Okay, now you can see the slides.
Yeah, but we have lost you in between.
No, no,
I
it's
think
okay.
there was some.
Okay.
Yeah.
So a level of 14 nanogram per ml, you got a difference in the HbA1c from baseline of 0.4%.
Hello, Dr. Mukhopadhyay.
My slide, not we can't start.
You see the slides?
We,
Yeah,
we have lost you in between. So I think
yeah,
we were not able to hear anything.
no, we had stopped talking because we found that the screen had become blank. Okay, so going from 40 to 43 helps from 0.4 to 1.81%. Going a little bit further, 62.71 nanogram per ml, your difference from the baseline A1C was 2%. So that's a very impressive figure. So all the three studies showed that vitamin D supplementation has a positive effect on HbA1c. But the point to note here is that there is a increment as that rising level of vitamin D gave you a better improvement in HbA1c compared to the baseline.
Here, I would just like to add, Hasnat, is that the Endocrine Society practice, from the US, they say that 50,
Yeah.
50, if you achieve 50, which is, according to them, going into the, lower limit of normal, you will be able to actually, the relative risk reduction for developing type 2 diabetes will cut down by 55%.
Yeah.
So just
Oh,
remember this number, 50 nanomole, and we are getting more than 50% reduction from, pre-diabetes to diabetes.
Okay.
uh,
And there's
uh,
still more to come. As the
yeah.
higher your levels go, you keep getting more and more benefits, not only the diabetic point of view, from other aspects as well. Can we move
But
to the next slide, please?
what I expect, sir, this is not nanomole, this is nanogram per ml, na? Because nanomole per liter is something that,
Yeah.
yeah.
Okay. Can we move to the next slide, please? Okay. So what is the importance of vitamin D levels in PCOS? I know, you know, PCOS is a condition of insulin resistance. And we've already seen from the previous speakers that insulin resistance is affected by vitamin D deficiency. So this was a study from the gynecologist, Dr. Gunjan Garg in AIMS, and they concluded that vitamin D supplementation had no effect on insulin parameters in PCOS. But if you look at another study, okay, from Dr. Toru Gupta from the FOXY organization in Delhi, they concluded that vitamin D supplementation had played a major role in the management of PCOS. And but you will now like to look at why this happened, why this one group did not get a benefit and the other group got. So if you look at Dr. Gunjan Garg's post vitamin D levels, 31.5 nanograms per ml, and the reduction in testosterone level from baseline, which is what we're trying to achieve in our patient with PCOS, is 25%. But there was no reduction in the fasting blood sugar level. If we look at Dr. Toru Gupta's study, the post vitamin D levels were much higher, almost 45. And the reduction in testosterone baseline was higher, 41%. And there was a 6% reduction in the fasting glucose level. So a incremental level will give you improved benefits. Can we have the next slide, please? Next slide.
ঠিক আছে. Hello? Hasnath, are you there?
Slide 2 has come.
I am there, sir. You are not able to see the screen?
No. It is. You are able to see the slide? Importance
Yeah.
of vitamin D levels and insulin management.
Yeah.
I need that slide. Okay, yeah. So that's come. Okay, thank you. So we look at the importance of vitamin D levels in insulin management in obese or overweight adults. We have a very short report on the left-hand side. Does vitamin D supplementation improve glucose homeostasis in overweight or obese women? It was a double-blind, randomized, placebo-controlled clinical trial. And this study done by Salehpour in 2013 showed that vitamin D supplementation doesn't improve any glycemic parameters in healthy and obese women. Whereas if you look at the paper on the right-hand side, where they looked at, again, supplementation of vitamin D and insulin homeostasis in healthy, overweight, and obese adults, they were not diabetic. Okay, and here they found that if you look at the levels, 38 for Salehpour's trial and Ebadi's trial was 38.6. They showed that a higher level of 38.6 showed improvement in sensitivity to insulin and the pancreatic function of beta cells of healthy, overweight, and obese adults. So incremental value again gives you a better importance. But you know, every nanogram per ml of vitamin D counts. Okay, so everything counts. Okay, so you do not think that, you know, I'll stick to my 30 old dictum of sticking to 30. You're happy with the figure of 30. So we keep going up the ladder. And this is a various studies. One is a randomized trial of vitamin D supplementation vascular function, okay, in CKD, and then another trial on stiffness and endothelial biomarkers. And all these articles showed that supplementation of vitamin D is beneficial for the improvement of vascular function in patients with CKD. But the question remains that again, over here, you can see the various authors. You look at post vitamin D levels of 33 versus 34 versus 38, and you can see there's a progressive.
Sir, you are on mute. Hello. So you have gone on mute.
I am hearing two voices on audio. It's a double echo. Please rectify that problem from your side.
Okay, can you hear me now?
Yeah.
So it is evident from this table.
Oh, there is an echo. There is an echo.
Can we move to the next slide if you can? No, that slide is there. Different slide is there. Yeah, yeah.
You can move to the next slide, but the viewers on OrthoTV will not be able to see anything.
On OrthoTV, we will not be able to see anything.
Can you hear me now?
There is an echo still.
There is an
Phone off though.
Mr. Rajkumar, we need the echo to be
Mr.
corrected.
Rajkumar, we need the echo to be corrected. We need the echo to be corrected.
Can the echo? Okay, so let me summarize this slide. It is evident from the above table that every nanogram per ml rise of vitamin D is important for its action on arterial stiffness as measured by the pulse rate velocity in CKD patients. So over to Dr. Mary DeCruz. Next slide, please.
Thank you, doctor. Now we have seen in pre-diabetes, diabetes, metabolic disorders, and PCOD that we do need higher levels to supplement the vitamin D and to maintain those levels. Now, looking at asthma patients with ongoing pollution everywhere, pollution in the air, pollution in sound, even light pollution, vitamin D supplementation as an adjunct to standard treatment of asthma. And this was a randomized control trial which concluded that vitamin D supplementation as an adjunct to standard treatment does not improve asthma control in children. However, a vitamin D supplementation in children may prevent the asthma exacerbation, which is triggered by acute respiratory infection. So, definitely, it has a role to play in respiratory infection, where we earlier saw slides that showed us that it causes an apoptosis of the infected cells, probably thereby reducing the trigger of exacerbations in asthma. So, significant benefits were achieved with vitamin D supplementation in asthma. So, these were the authors. Thakur et al. Showed post vitamin D levels at 35.5 nanograms, and it did not show any improvement in the post expiratory volume 1. However, Majek et al. Showed just a level of 37.6 nanograms, just two more, and showed a significant improvement in the FEV1 levels. So even 1 nanogram per ml actually makes a difference in people who suffer from from asthma. So it can be seen that when you raised it from 35.5 nanogram per ml was not associated with improvement. However, just 2 nanograms of 37.6 was associated with an increase and a reduction actually in asthma symptoms. So, vitamin D levels in chronic obstructive pulmonary disease, the impact of any vitamin D on spirometry findings, and the quality of life in patients with chronic obstructive airways disease, a randomized double blind, placebo controlled clinical trial concluded that vitamin D supplementation is definitely beneficial for COPD patients, and the effect of daily vitamin D supplementation on respiratory muscle strength and physical performance in vitamin D deficient COPD patients in a pilot trial showed that vitamin D supplementation failed to show any benefits for COPD patients. So, a little bit of controversy, but I suppose it is probably the levels that we need to raise it to. So, Faumani et al. Showed that post vitamin D levels at 51.83 nanograms per ml showed a significant improvement in the lung functions vis-a-vis the FEV1 levels. Whereas Rafiq showed that 37.7 nanograms per ml, there was no significant improvement in FEV1 levels. So it looks like some of the other metabolic disorders, diabetes, even respiratory diseases would need levels of 50 nanograms per ml plus to be able to give benefits to these patients. So data suggests that 37.7 nanograms per ml would be sufficient as per recommendation but not associated with improvement in the COPD symptoms. However, when you raise it to 51.83 nanograms per ml, there was a definite improvement in the COPD symptoms. So we can provide benefits to our patients provided we step up the levels at which we are looking at sufficiency. So I hand over to Dr. Basu.
So this is next slide, please. দিয়েছে আমার সেটটা দিয়েছে so yes uh, so this is a slide which talks about the effect of vitamin D on depression. Now vitamin D, obviously we know it has antioxidant properties and activity in the brain.
Sir, a little audible, sir. Little.
Vitamin D has antioxidant properties and activity in the brain tissue, and it is important for mood disorders, prevention and treatment. We still yet do not know the serum levels, correctly for that, but we have got trials here. I will just tell you briefly that vitamin D has a major role on neurotrophy, monoamine neurotransmission, and of course we know about immunomodulation. Having said all that, these two trials that you see here, Jodes trial and the other one is the Bijlani trial. Jodes trial say that the vitamin D achieved was 34 and no significant improvement in depressive symptom score did happen. But in Kavian is what this showed was 8-week supplementation of 50,000 international units every 2 weeks for the elderly people. They had elevated vitamin D levels, which was around 53.5, and definitely they had improved their depression severity score. So this is very important in elderly population. If we start giving, vitamin D levels, maybe that can prevent early aging, cognitive dysfunction, what we call Alzheimer's, depression, anxiety. All these are modern day symptoms today. I mean, if you're living in a modern society, these are the ailments you have started living with. So vitamin D has an action. This is a paper on psoriasis, and why not? Because we know the impact of psoriasis of vitamin D in psoriasis. 2 papers, one achieving 30, that's Jensen's paper, 30 nanogram per ml, where we did not see any improvement in the psoriasis area and the severity index. This study also had vitiligo subjects. They did not find any change either.
So your voice is not coming again.
Now, hello? Hello?
Yeah.
Okay. So,
So I think you need to keep it very, very close to your mouth.
yeah. So I
Okay.
will talk about 2 studies in psoriasis patients. One is Jensen's paper, which has psoriasis and vitiligo subjects. The post vitamin D level achieved was around 30 nanogram per ml. There was no improvement in the psoriasis area and severity index. And obviously, there was no sign of hypercalcemia. But in the Finamor's study, they achieved 106 for psoriasis cases and almost 135 for the vitiligo cases. And they showed classically, in all these 9 cases, they showed almost 25 to 75% repigmentation in improved in Finamor's paper. Now, vitamin D, I'll brief upon the actions. Next slide. The actions of vitamin D on the skin is, it has a psoriasis pathogenesis, is all with the deficiency of vitamin D. The regulation of keratinocyte proliferation. When you see the stratum corneum, sunlight hitting the UVB, hitting the skin, all those 5 strata, the stratum, they have their action. And you have keratinocyte, proliferation action, the immunomodulating action, these Treg cells coming out, they all have their individual component. So vitamin D regulates keratinocyte proliferation, differentiation, and apoptosis, regulation of cutaneous immune system, the inhibition of T cell proliferation, the regulatory T cell induction, the downregulation of the pro-inflammatory cytokines, the stimulation of the antimicrobial peptide expression, they all happen with vitamin D. And it can be therefore seen. Am I audible, Hasnat, am I there?
Yeah, yeah. Yes, sir.
So it can
But
be
but
seen
but
as a,
but the voice was quite low.
well, I think, physiologically, this is what we can achieve. I mean, so the data 30 milligram nanogram per ml, which is the sufficient, by deficient, the lower level, was not associated with any improvement in the PASI score. But when it went to 106, definitely it was associated with the improvement. So there are studies which share that the significant inverse relationship between PASI and 25 hydroxy vitamin D. So uh, you have to keep it more than 50. That's the objective. The bottom line is when you're treating psoriasis, you need to understand that if it is not 100, choose somewhere where it is visibly between 50 and 100. And of course, more than 50, certainly. Now, when we're talking about the Treg cells, let me touch upon the next slide, where we talk about the level, the Treg cells, the level of vitamin D on the regulatory T cells and apparently healthy subjects. So how this vitamin D actually will have an impact on the autoimmune diseases, whether it's a multiple sclerosis or a rheumatoid arthritis, any autoimmune disease, vitiligo, you name it, and vitamin D has a role there. Now, this is Preeti's paper, which says that you are achieving 58 nanogram. Then you've got significant increase in your expression of the Treg. And then Mabosh's paper, which says 32, there's no impact. So again, same illusory 30, which is of course sufficient, but absolutely low level of sufficient. And 50, which is classically somewhere in between in our Indian community, the practice, will be very happy if it crosses 50. So here they're showing classically that the Treg expression is happening. There is a positive impact at the level of 50 and above. The next slide. The next slide we are showing, this is on Hashimoto's, right? This is on Hashimoto's thyroiditis. Hashimoto's thyroiditis, well, a very interesting slide. Hashnath, thank you for this. It actually results from the chemo attraction of the inflammatory cells towards the thyroid gland by inducing the production of something called interferon gamma induced protein 10. And this is done by the T helper cells. This is from the adaptive immunity. Now, vitamin D can actually suppress this IFN gamma IP10, but this new function of vitamin D actually has not been investigated till I saw your slide. Now, daily dose of vitamin D usually does not affect the Treg population that way. But only the seasonal changes of Treg population, as you know, for thyroid cases, we say do the TSH and the free T4 in the winter, the climate change and all. There, if you are constantly giving even a standard dose of daily dose of vitamin D, these changes might not happen. In this slide that you've shown here, one is on the general population, on the Hashimoto's thyroids treated with L-toxin. The other is a low dose vitamin D. That's which I'm saying. Seasonal variations, the changes in the T cell, they are been taken control. So a level of 50 nanogram again of vitamin D exerts a greater and potent inhibition of the interferon gamma expression compared to the one at 30. So this is again, we are talking about these, very important markers, which are actually protective markers. Now, as we were talking about vitamin D, 125 hydroxide coming into the nucleus, getting connected with the RXR, the genomic expression happening. In that phenomenon, we have another pathway called the MAPK pathway, which is signaled, which is a non-genomic pathway. And there you have these, products like cathelicidin expression occurs. Now, these are all activated these are all activated mitochondrial proteins. These are induced by vitamin D signaling, cathelicidin, defensin, hepcidin. They're all peptides. They're intrinsic antibiotics, actually. They have been given by God a direct antimicrobial activity within the cell against various pathogens. Now, if you've got antimicrobial resistance now to any of these common antibiotics, maybe this is what is protecting us. We have got a lot of drug-resistant pathogens. We know about the mitochondrial TB Mycobacterium TB resistant MTR, where maybe these host defense peptides are extremely valuable candidates keeping us alive. So there is this one way of addressing this issue that, Sharifi's paper, when the vitamin D is now 41, there is a threefold increase in the cathelicidin expression. In Mabosh's paper, it is 36, not that much, but 1.2-fold increase in cathelicidin expression. So what I'm trying to tell you is that is significant increase of cathelicidin happens with the expression or with the institution of a fundamental idea of a vitamin D that will take your blood level to more than 50. That should be your target. In the autoimmune cases like Crohn's disease and all, maybe higher doses of cathelicidin concentrations are required, and then you have to pep up your vitamin D supply or supplementation accordingly.
Can we move to the next slide, please? The effect of vitamin D on epigenetic modulation. Okay, we started the program, we were looking at levels of 20 and 30. We've now moved to 40 and 50. It's like this handshake. You've got a support level. The support level that at the moment is a minimum of 50. So we want to see, is it going to move up further? All right. Okay, so this is a very important study by Shirvani, in collaboration Dr. Michael Holick. I'm sure you've heard about Michael Holick. He's the father of vitamin D metabolic.
So we have lost you in between. So, we are not able to hear, sir. We are not able to hear, sir. So we are not able to hear anything. No, sir. No, we are not able to hear.
Can you hear me now?
Yeah, it is now. Yeah.
Okay. So let's look at a little bit at the epigenetic modulation of vitamin D. Okay. Epigenetic basically means that there's some regulation of the genes without actually changing the structure of the gene. Okay, so this is done in an important way by vitamin D. This is a paper from Shirvani and in collaboration with Dr. Michael Holick. I'm sure you heard about Dr. Michael Holick. He's supposed to be the father of vitamin D metabolism, has a lot of landmark studies, and they looked at differences in gene regulation that are involved in cell proliferation, differentiation, and immunity, but different levels of vitamin D. And as I said, I warned you. Okay, so let me look at your different levels. You can see the bar diagrams on the right hand side. You can see the blue bars are the upregulation, the orange ones are the downregulation, and the total is in green. So if you look at a level from moving from 24.3 to 78.6, there is an 8-time greater influence. If you look at a level of 40.8, the difference between the 78.6 is about 4 times. So this is important. So as I mentioned,
Have we lost them? Hello?
Yes, sir, we have lost them.
Okay. Ah, so we have lost you in between. No, sir, you
The
are not
audio
audible.
is not there.
No, sir, your voice is not there. You are not audible. Sir, your voice is not there. Hello? No, sir, you are not audible. No, sir, you are not audible.
আমি সেটা তোমার সঙ্গে ডিসকাস ওভার লাঞ্চ।
নাচ করে গেছে কিন্তু পয়সা পড়েনি ভাই, দেবো কি?
Yeah, sir, now you are audible.
শুনেছে বেটা ছেলে,
Okay.
হাসনা।
Okay.
Yeah.
So I'll go through this slide again. I think this
Yeah.
is a very important slide. Okay. Um, Dr. Shirvani, along with Dr. Michael Holick, who's the father of vitamin D metabolism, there was the first time that they reported in 2019 that there were differences in gene regulation that are involved in cell proliferation, differentiation, and immunity by different levels of vitamin D. And that is the reason why the vitamin D has a wide range. It's got a what we call a broad spectrum range. If you look at pulmonary diseases, you look at autoimmune diseases, you look at type 2 diabetes, insulin resistance. So why is it helpful in such a wide variety of diseases? Is because it has upregulation of genes at different levels. So if you look at a level of 40.8, compare it with vitamin D level of 78.6, there is a fourfold increase. Okay. If you go from 24.3 to 78, there's an 8-10 increase. And that is, I think, makes it, I always say that vitamin D is not a vitamin, it is a metabolic hormone. And that is why it's got, I will say, a broad spectrum across all the various ranges. So over to Dr. Debashish Basu. And next slide, please.
Yeah, I mean, a very important topic that we, in a slide that we discussed. It's a whole human genome program where it revealed that more than 1,200, almost 1,300 genes were expressed differentially, upregulated, downregulated. Whatever it is, the increasing level of vitamin D3 from 4,000 international units per day to 10,000 international units per day had no additional impact, mind you, on the PTH level, which people worry about. I mean, when we start writing vitamin D, we think about toxicity, PTH level. Nothing was seen, but the good expression of the better genes really showed up, and that is where the magic of Michael Holick comes in. So, my next slide is. Now, current available cholecalcium. Now, this is a very this is the mystic part of the management, right? So, people have now huge, a wide array of choices. You have tablets, you have soft gelatin capsules, oral disintegrating strips, oral spray, oral solutions, IM injections. Now, there are so many preparations you can choose, but what would you choose? Are they all the same? So, what is next slide? What is delivered is actually not what is promised. Now, this is a good study by Khadabad, which says that when you're looking at the disparity of the cholecalciferol content of the commercially available preparations in India, you look at the suggested range by the Indian Pharmacopoeia, and then you see the percentage deviation on the right from the claimed strength. This is what is happening. Plus 65, plus 31 tablets, minus 34, minus 60, absolutely pulls apart. So how can we take it forward? Next slide. The challenges with conventional formulations of vitamin D, yes, of course, we have to understand that we know vitamin D3 is a liposoluble product. So dietary fat, of course, can increase its oral absorption. So these are the studies. These studies by Rajmund and all. They say that if you're giving high fat meal, low fat meal, and then you're taking cholecalciferol orally, what are the changes happening? So in this there's a clear data saying that the red one is the high fat meal. So you have the vitamin D level going after 7 days, 14 days, it's rising. Whereas if it is a low fat meal, it is going down. It is having no impact, in fact, negative. So when we are talking about the bioavailability, we must understand that vitamin D absorption, when you're having an oral dose or maybe you're having it in diet, it's the chylomicrons which will carry the vitamin D in the whole system. And these are all dependent on the bile secretions, the micelle formation, the gallbladder, the CVD, the common bile duct. When you come there, you go inside those areas, you'll see this changes happening. And the diffusion, finally, it comes out from the CVD, it falls in the second part of the duodenum, mixes with the pancreatic juice, then starts going down. And then the diffusion starts happening in the unstirred water layer on the enterocyte. And the compliance happens with these vitamin D different categories that you have, whether you're having with milk, whether it's having with ghee, or whether it's having with water. But every time you're taking a 1 vitamin D capsule a day, maybe 2000 and you have to choose your ghee, maybe you will die of a heart attack and stroke much before that you hit the target desired vitamin D level. Now, the limitations of the oral formulations, they largely depend on the lipid absorption pathway for their absorption. Then, as I was saying, ghee, butter, milk, curd, and all that, they are needed for better absorption. And there is inconsistent oral availability. As Indians, we have a gut issue always. I mean, we are actually gut people. So, and we are very unpredictable. So there is a poor, inconsistent oral bioavailability. And as a Bengali, I claim as a leader in this gut aspect. The compromised lipid absorption, the bioavailability from these lipid formulations, they are definitely questionable. But I would still suggest that there are different, out of these groups, maybe a microencapsulated vitamin D, an oil-based vitamin D, micellized vitamin D. We now have to see how they are given, in the animal models, in human models, and then realize every 7 days or every day 7 days, what are the results? How does this most bioavailable, impact shows up in your blood level? So we need to understand that. Then there are these challenges with the absorption of vitamin D. So as I was saying, chylomicrons. So that pathway is lymphatic. So you will have it is absorbed, then the lymph gland will take it near the intestine. We know that about that. There is a large inter and intra variability in the vitamin D absorption. If you know that in our mouth we have a 5 to 7, that's a pH. The enzymes are tyline and all. In stomach it is around 3. The enzymes they are there, pepsin and all. In the small intestine it is 6 to 7.5. In the colon it is 5 to 7. So there are various areas where the enzyme absorption and activity, they are differing. And we also know that the role of individual gastric enzyme has its impact. Mechanism of vitamin D transfer to the fat phase is also very difficult. The effect of lipophilic compound on vitamin D transferring into that phase, hydrolysis of the ester from vitamin D by the gastric lipase. So these are very, very difficult pathways that it has to undergo. The intestinal also has a pH. It has a role on the vitamin D stability. So it has to be very stable. It has to be very organized, and it has to deliver a correct absorptive dose every time we are giving the product. So next slide. So we need to understand that out of this myriad of complex situations happening in that, this is 18 feet small intestine and then 5 feet maybe large intestine. A lot of changes are happening every then and now, and we need to have a novel technology to deliver the right dose of vitamin D at the right time for the right result. So there we have this Nanocarrier entrapped vitamin D3 to enhance the oral absorption of vitamin D3. And what are these nanocarriers? Next. Nanocarriers are involved in drug delivery. They offer several advantages when compared to the conventional treatments like all these capsules and tablets that we have, allowing an increase in water solubility of slightly soluble and insoluble drugs and the protection against degradation and inactivation. I mean, if you are a diabetologist and watching this program, you might know what is semaglutide and Rybelsus, how we know how it is giving that big impact. The world is shaking. It's actually losing weight because of that. It is because of that drug delivery mechanism, the snack. Similarly, the fantastic methodology behind Nanocarrier is that these characteristics actually provide enhanced stability in comparison to the traditional formulations. And further, the design of these nanocarriers involved in the drug delivery facilitates the drug lingering in the blood system for a prolonged period of time. So maybe what you're doing, loading for one every day for 7 days, then you wait 7 days, 10 days, 14 days, maybe a month. See the impact. This supports the efficient accumulation at the site of action. And a necessary feature that I must tell you here is that it facilitates dose reduction to patients with a consequential decrease of the adverse effects by the drug, formulation and the adjuvants. See the hydrophilic layer. See the lipid nanocarrier The vitamin D molecules are within that. That's like the egg yolk where the vitamin D molecules are. The pH resistant electrostatic barrier is there. So you, whatever pH I was talking about, saliva, stomach, intestine, small intestine, and the large intestine, it is resistant. Enzymatic action, breakdown, peptide. Maybe even if you have a, peptide breakdown is very difficult. It's very easy. But here, vitamin D breakdown also can be easy because of the, the lipophilicity of it. And finally, we have the zeta potential. So this actually gives you the very integral stable structure. And then it goes down in the system. Next slide. Is it mine? So it has gone down now. It has come to the absorptive area, which is, where we know that it has to be very, very optimally available for all of us. You have sterically stabilized these T3 nanoparticles, which are less than 150 nanomoles. And then they are coming in to that, the mucin layer above the enterocyte. They are getting adhered to that, the mucus layer, the mucin layer. Then there's a transcellular pathway gradient, which is happening. You see the M cell? M cell is the pairs patch, the pair patch, that is the M cell. They are now slowly getting inside that tight junction is opening up, and they're going in like paracellular transport or maybe a passive diffusion. There is a digestion by the pancreatic lipase. There are bile salts coming in, and the mixed micelle formation now is ready for slowly getting inside very passively, because they have opened up the segments which are, they are very easily penetrating through that thin water layer of that mucin. And you have no problem in actually waiting for those molecules to get adhered on the water molecule. There is no problem in actually working it as a barrier or a resistance. It has given up. It has actually welcomed. It has embraced the absorption passively to go into the system. So we need to understand this enhancement of the uptake by these appropriate cells, which actually will take up the molecule for the proper action. The modeling surfacing properties to optimize the access and transport by the M cells occur here because of this nanoparticle production, the carrier molecule. So we are extremely happy the way the nanoparticle transcytosis happens, because we see results after that. And therefore, the feature, next slide, the features of nanocarrier entrapped vitamin D oral solutions are that, next slide, unlike the other currently available traditional formulations, nanocarrier entrapped vitamin D, that egg yolk, does not depend upon any other lipid digestion process for its absorption. The nanocarrier entrapped vitamin D3, it shows rapid gastric emptying, thereby increasing the rate of absorption. Nanocarrier entrapped vitamin D3 is unaffected by the gut pH, entire throughout the length. Nanocarrier entrapped vitamin D3 absorption is unaffected by fat-fast variation, or maybe you're having, it's a, no fatty meal, etc. is required. So you have a very predictable oral bioavailability. Because of its very small size, less than 150 nanomole, and that surface charge of zeta potential, the nanocarrier entrapped vitamin D3 rapidly accumulates in that mucin layer. From there, it enters an unstirred water layer due to its hydrophilic surface. Now, you see, you had seen that hydrophilic surface was there in between, and now that will become friendly with this mucin layer. And then it will be slowly transported across the enterocytic membrane, passively, or maybe by, as we said, the paracellular transport, by the transcellular pathway, by muc addition. All these will come and help the molecule get inside the capillaries. So next slide.
Yeah, Dr. Debashish. Now, I think moving on to the clinical trial part, before that, I would like to have a few words from the Pulse Pharma, Mr. Samar Ghosh, who can speak on how this technology was actually came into existence and why it is very essential for this, the physicians, to know about nanoscience in today's world and what actually is nanoscience, because we are heading towards a nanoscience journey, especially in oncology. It is well known. So why this is so important in current practice? So I think he can highlight some of the parameters that were taken into consideration while making this molecule, or why this has come into existence?
Yeah, thank you, Dr. Hasnath, and thank you, the dignitaries. I have been listening from the medical who's who at Calcutta. And thank you, Dr. Basu. You have chosen this particular place, where 22-degree latitude and around 88-degree longitude, and in between 11 to 3, and at 42 degrees Celsius. So every reason why the thermal UV B exposure is not adequate here. And entire India is listening possibly, and sorry for some technical glitches, what we have experienced, and which was beyond our control. Yeah, coming to the question, and what has been cited by Dr. Basu as well as Dr. Mukhopadhyay and Dr. Cruz. 10 years before, when this was brewing nationally as well as internationally, that the myth was the tropical, being a tropical country, we should not be bothered about vitamin D deficiency or insufficiency. But that myth was burst, by the medical fraternity, and it is not only just getting rampant, but almost like a silent pandemic. And it is, though there was no direct correlations between whether it is a causative factor for different kind of diseases, but definitely one of the complementary factors for different kind of issues, both calcemic as well as non-calcemic. And the way Dr. Basu has made a dissociation between calcemic and non-calcemic relationship with the vitamin D3, which is commendable. So the organizations, Pulse Pharmaceutical, actually started realizing 10 years before that this is an elusive vitamin D, which is most read, but a lot of confusion around because the interpersonal variability, the challenges to create a right formulation in today's context, so much of unstable formulation, how to make it stable. And the first generation, the promoter, Mr. K.V. Rambabu of Pulse Pharmaceutical, has chosen the difficult path to get into not creating another Me Too vitamin D3, but has set up one of the world-class R&D centers in Hyderabad, who had made a designer baby after a lot of clinical research, and that is today what we are talking about, Nanocarrier entrapped vitamin D3. The Pulse Pharmaceutical has been only talking about the kinetics, the pharmacokinetics. And the pharmacokinetics, we are having like BCS class 1, 2, 3, 4 drugs. And vitamin D is coming almost in 3 and 4 drugs once you are looking into ADME of kinetics, what the body does to the drug. So to make vitamin D, whatever you are getting it in the formulations in the body, there are certain two things were actually coming in the way. One is first to make it stable. Next one is making a stable formulations which is also palatable, so that it should be patient specific. And third one is it should not have a sort of a drug kind of appearance. People should feel with a lot of happiness. As far as vitamin D, ultimately it is coming from the sun sign. You just can't have a pill burden for everything, especially for those patients who have been taking so many pills. And that is extremely important when an innovation-driven R&D company has created this product, which is not only has made a stable, but a carrier protein which is entrapping number of vitamin D3 into it and navigating it through all the complicated in vivo systems and reaching, as Dr. Basu rightly said, through the unstirred water layer and to the enterocyte. And that is the phenomenal in terms of irrespective of patient type,
it can really do wonderful job in terms of predictability. But of course, we are not fiddling with the molecule, so that if somebody is already there, vitamin D resistance cases, or the enzyme, is not getting into liver, which is converting from 25 to 125, there possibly, this is not going to really work, and we don't talk about. We only talk about how to give the product which is extremely stable and reaching to the enterocyte irrespective of patient types in a right way. And that is one of the beautiful things which has happened and making a difference in the patient's life. So, Dr. Hasnath, I think to answer you, the organization has found out the sweet spot in the kinetics, and that too, as we said at the beginning in our corporate AV, that in nutritherapeutics, nanotherapeutics, and cell therapeutics. So in nanotherapeutics, our vitamin D3 is one of the products which the fraternity is actually vouching for its either the stability as well as the merits, what is actually getting passed to the millions of patients. And last but not the least, we have adhered therapeutic stringent quality control. We have never seen this product as a supplement. So that's why this product, whenever we have taken it up, it is as per therapeutic standard of producing the formulation. So this is one of the very important thing. And today the worry part is like that so many liquid formulations are coming, and the liquid means nano means good. I think we need to be more responsible that how the Nanocarrier entrapped vitamin D3, with a characterization which is safe and reasonably sure for the predictable rise of 25-hydroxy D3. That is exactly what we are aiming for, and I am pretty sure all my the respected the speakers as well as the learned audience would be able to really, the subscribe to this idea. Thank you.
Thank you, sir. Thank you. Now, for this quantification of what Mr. Samagosh has just said, I think Dr. Debashish can go through the clinical trials, because I think Nanocarrier Entra Vitamin D3 is the only vitamin D present in the market which has more than 7 clinical trials, and more coming into your way. So, some of the highlights of the clinical trial, Dr. Basu, you can definitely highlight. I can add to my points what I have observed during this, and definitely other speakers can also have their part today. So I think we can switch to the clinical trial part. We can have some clinical highlights of this molecule, why this molecule is the best vitamin D. I'm claiming the best because that is what the clinical trials shows, superiority over any other vitamin D formulation, and so far and so forth. So we can move to that part. I can just skip my screen to that part. Yeah. We are over to that.
So, I mean, we are talking about from nano, micro, we are now coming into a macro impact, an impact which can actually change the world. If we meaningfully understand what we were talking about, the pathophysiology, and then pharmacology, and finally translational medicine. We were talking about basics, the micro part of it, and now it is coming to that macro level when we understand, and then finally, knowing is not enough, we have to apply. So here is the clinical trial. Hasnat, Baba, can you go to the clinical trial thing?
I have already switched to that, sir. You are not able to see my screen?
You can see, fine, then no problem. Then let me continue. So this is a trial which actually talked about, entrapped nanocarrier, entrapped vitamin D3 versus capsule versus granules. So what they did was, this is Lucky Reddy's work in Hyderabad, in Telangana. What he did was he put these patients who had mechanical lower back pain, and he subjected them to a dose of 60,000 IU once a day for 10 consecutive days. Then in the other segment, he did for the capsule 60,000 IU once a day for 10 days, then granules once a day for 10 days. What you observe, you look at the blue, orange, and the gray. Blue is the granules, orange is the nanocarrier entrapped vitamin D3, and the gray is this capsule. So baseline, more or less, the vitamin D level was same, around 15, hovering around 15. That was average. Now, after giving these preparations for 10 days, on the 21st day, after 3 weeks, they did another assay and they found that the oral solution became 96. That gave an optimum figure of vitamin D to 96 compared to 68 for the granules and 62 for the capsules. Now, what I am trying to say here that these subjects, of course, in the nano syrup group, they have shown, not only significant improvement in the vitamin D levels, but what here is not mentioned, and I can tell you because I read the paper, is that pain and functional disability were also assessed from the visual analog score and what you have, what we call the modified Oswestry low back pain disability questionnaire. There was improvement. Now, this is just because the direct impact of vitamin D in the immunomodulation, in the pain receptive pathways. So there is a big area of the action of vitamin D. What I'm trying to say, there are genomic, non-genomic. It's still a molecule, I think, which has not. It's like Lord Krishna. It is still in the stages, early stages of Gokul Dham, its life, his life. So it will, give that Vishwarup darshan if we start all putting in our minds together from these small studies and apply these in our cases. Next slide.
Yeah. So I would also add to your points
Please,
here
please.
on this clinical trial. So what basically is this clinical trial, or why it is so landmark to have this trial as our basis? If you see, this is a continuous therapy of 10 days. So we see a lot of compatibility issue when we give weekly or monthly therapy. So that is why we have switched to a daily therapy, because it gives you a consistent and a faster rise as compared to your weekly. Because weekly, when you give, you can hardly, I can imagine, you can go to a level of around 96, which is very possible with this daily therapy. Secondly, if you see the measurement of what you say, the post-treatment measurement of vitamin D or 25 hydroxy was done on 21st day. Why it was done on 21st day? Because if you see, the half-life of 25 hydroxy is around 2 to 3 weeks. Taking around 3 weeks, it comes to around 21 days. So that's why the post-treatment is taken on 21st day, because of the half-life of 25 hydroxy. When you see the levels, it is 96, which is I think, which is not possible from a weekly therapy or a monthly therapy. So switching to a daily therapy, which is known as pulse D therapy, for 10 consecutive days gives you a rise of 96. And why these levels are very important, that has already been shared by our esteemed guest. Why reaching to this level is so important. So I think this is one of the landmark study, 10 days continuous therapy, pulse D therapy, reaching to a level of your 96 nanogram per ml, which is required in your conditions. Speaking to the next trial, when we say we have compared, we have also done a trial against IM injection, intramuscular injection, same therapies, pulse D therapy for 10 consecutive days. And again, if you see, on day 10, on day 10 or on day 30, this trial was for 30 days. We have seen a consistent and greater increase as compared to IM injection. On day 10, it was 71, which has come down to 60. Of course, once the the saturation will be occurring and it will go to a steady state. So the steady state will be attained. But anyways, the steady state is more for the oral as compared to intramuscular. That comes to a point where I would require your esteemed guest, your some opinions, how you see oral versus intramuscular injection in this regard, because we have seen oral far superior than intramuscular injection in trials. And I think this trial is a prime example of this, giving continuous 10 days therapy up, versus an intramuscular injection. It is firmly believed that intramuscular injection gives you an acute rise, but it is not how it has been proven in clinical studies. So I would request your opinion on this thing, Dr. Basu, Dr. Cruz, and Dr. Mukhopadhyay. Your views on this thing.
Yes. First, Dr. Mukhopadhyay, the senior most.
No, you're absolutely right. We've never used IM between D. It's mostly used, by the orthopedic specialist. We've always found, particularly after the nano carrier entrap vitamin D has been available. Giving it in whatever dose you want to, okay, you get a much better rise in a very safe manner. You don't have to give the injection. The vitamin D is fat soluble, so it is a painful, actually. That is one of the reasons difficult to give it. It is normally given in the buttocks, and so I think that was always been a problem. But after this technology appeared, I use a lot of once a day for 10 days to get and do get miraculous benefits. So, patients will who have been unable to walk, low back pain for months and years, are now actually almost running around. Okay, so I think this is important to, and of course, we will also discuss what to do. You've given them 10 days of therapy, you got their levels to 96. What are you going to do? Okay, that will depend on a individual basis. So, Dr. Mary DCruz, please.
Yes, I think anyway, the patients are always hesitant to take any kind of injections. And then proof is here that when you give an oral solution, you're getting far better results. So, why wouldn't we do that for our patients? And symptom improvement is almost instantaneous. They will tell you the next day that I have got improvement in my muscle weakness and pain. Probably a little psychological, because we try and tell them that this is one of the best things that you are receiving. And so they come back or they phone and say that, yes, I am much better. So definitely oral solution is the way to go forward. Definitely at day 30, we see that the levels are slightly dropping. So we need to reinforce and continue giving it at intervals to maintain those levels. Thank you.
Yes, of course. I mean, look, one thing I believe that whether it's a bone pain or whether it's a pain from the injection, pain is inevitable while you live your life on this earth, lonely planet called Earth. But suffering is optional. So, before this kind of a data, we did not know that an oral preparation, whether it's a nano particle or it is a granule, whatever tablet, will give us this kind of an impact. So when people used to come with, as Dr. DeCruz said, that three fatigue, like she's going to the grave. So what you do is immediately think about pushing a shot in the bumps and believe that immediately the vitamin D tomorrow morning will give you the optimum level, and you will be very happy, jumping in joy. The whole point is what she and I had been doing is we had been actually trying to choose the right attitude to convert that negative state of that woman into some kind of a positive one. But we did not have this idea. Today, now, as you clearly showed in this date on the file, that the greatest weapon against this kind of a situation, stressful situation, stress for her and me as a doctor, is our ability to choose the better over not so better or the other. And that's where you have completely given us this picture that we have understood that in the middle of so-called difficulties, there lies an opportunity. There lies a hope. Thank you.
So what I get from this point is your intramuscular is not for acute phase increase in 25 hydroxy, as it was a myth that it causes increase, whereas your oral causes a far more increase in the acute phase, you know, and a gradual.
Gradual. You don't need
Yeah,
to have something exponential because the cells will get confused. The
true.
cells, too much of gene expression may happen. I mean, Dr. Hollick also might not expect that suddenly you pump in iron injections. We have seen this. We said one injection once monthly, say for 3 months. In those cases, one injection twice a day. You never know on the fourth day that thankfully that will not have an impact, like it will not shoot up. Had it been absorbed like an IV injection, had it even that doesn't matter. The IV injection will not actually dissociate the vitamin D to get
True.
absorbed capillaries to go into the bloodstream to get
Hmm.
so these are all our protective. God makes our own defense system. However callous and careless we are, maybe God will protect the person whom we are
True.
treating. So here, as you said, you showed that the increment is absolutely exponential and on a timeline very linear, which is very happy, which is very healthy for the cells.
Yeah.
But as Dr. Biku said, that we understand by 12 weeks, it will start again falling. So why will we wait for 12 weeks to get to these desired, levels? As you said, we are doing because of the half. But I'm not saying doing the test, the next dose. Next dose when we die, right?
Yeah. So thank you, sir. I will just move on to the next thing that
Yeah,
when patient is it. Yeah, sir.
I'll just add one point to what
Hmm.
Dr. Basu has talked about.
Hmm.
That so we are now going to practice that how to correct and maintain
Hmm.
vitamin D level. And there was a myth possibly that when you go for IM,
Hmm.
25 hydroxy D3 is shooting up. It is not so. Cholecalciferol, you might get it in your blood,
Yeah.
but not 25 hydroxy
25
D3,
hours. Yeah.
which we are measuring.
True.
But once with the advent of this kind of formulations, we could say that it will go much faster through the lymphatic systems. So
Hmm.
25 hydroxy D3, if our purpose is to really elevate much predictably, I think this could be a natural choice, not the IM, which is
Hmm.
totally a whole different, which possibly was in practice phenomenal, even by the general practitioners.
True.
So this is something I think we are delighted that once we learn from this August gathering and getting to know and the interpretation. So it is getting disseminated with so many other learned audiences to make sure that we improve the quality of life of the patients accordingly with the right
True.
choice. Thank you.
Yeah. I would just, what you say, medically put this thing from Samar sir. What he actually means is when you take oral supplement, it directly goes into your lymphatic system, and lymphatic system drains out into liver, which causes an increase in 25 hydroxy. Whereas for intramuscular, it is not the case. Intramuscular goes to your muscle and then to your direct circulation, from where it goes to your hepatic circulation. So it causes a delay in an increase in 25 hydroxy, which is the actual target for most of the receptors, vitamin D binding protein. So that is where the point is actually coming from. Oral causes a far more superior and predictable early rise in 25 hydroxy as compared to your delayed intramuscular injection. So now that comes to a point when that says when patient is in need, time is our prime. And again, as we just rightly mentioned by our delegates, why to wait for 12 weeks to get to the desired vitamin D level? So again, I would just summarize this point in a very quick way. So three therapies that one can target while going for a rise in levels. So we have 10 days continuous nanocarrier enter vitamin D formulation, 10 days continuous therapy, 5 days, 7 days. So right from 5 to 7 to 10, you can get a predictable rise. For 5, you can get to a level of around 45, which is ideal. What I think of is an ideal for a normal human being. A healthy human being, 7 days to reach to a level of around 51, which is ideal for a patient who is suffering from metabolic syndrome or for any condition which requires a level for around 50, and can go to a very high level of 96 from a 10 days therapy, for especially for patients who are suffering from musculoskeletal and from autoimmune conditions. So that is what I get from this. So continuous therapy over weekly therapy or monthly therapy to get to the desired level is what is achievable. Moving to the next slide, which is very important, and I think uh, 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 Miss Cruz can get us to this. The risk of toxicity. We are talking about this levels, but is this safe for a normal humans? So I think
Right.
over to you, Dr. Cruz.
Thank you, Dr. Hasnath. And the fact is that we all practice evidence based and ethical medicine. And so we are always fearful whether the doses that we are going to give are going to harm the patient. So, premium non nausea, that means we must not cause any problems for our patients. So, we fear toxicity. Now, we have seen that recommended levels for sufficiency are 30 to 100 nanograms per ml, and they are found to be acceptable under many guidelines without any risk of either hypercalcemia or a risk of kidney stones. So these are the major challenges, and we saw in the clinical trials that were presented that in spite of giving a daily dose of 60,000 international units, we do not reach toxic levels. So, what is the risk of toxicity and what are the actual acceptable levels? There are only a few articles actually that correlate vitamin D with hypercalcemia. And on this recently published data showed the relation of vitamin D with hypercalcemia. Almost 84% of patients with 25 hydroxy D levels more than 88 nanograms per ml were found to be normocalcemic, followed by around 15% who had mild hypercalcemia, and only 0.6 and 0.4% were found with moderate and severe hypercalcemia. Looking at a distribution of 56 patients who had a 25 hydroxy vitamin D level of more than 150 nanograms, what was the evidence? 75% of patients with 25 hydroxy levels more than 150 nanograms per ml were also normocalcemic, followed by about 23% with mild hypercalcemia as compared to 15% in the earlier slide, and only 1.8% had moderate hypercalcemia. So there was no case of severe hypercalcemia in individuals with 25 hydroxy vitamin D levels more than 150 nanograms. And we have been seeing the various trials showing us that even levels of 100 are bringing marked improvement in the patients. So, what are the risks of toxicity and acceptable levels? There was another study published in Mayo Clinic in 2015, and that showed that the incidence of having 25 hydroxy vitamin D levels above 50 nanograms increased significantly between 2002 and 11 without a corresponding increase in acute clinical toxicity. In the same study, it was shown that the incidence of 25 hydroxy vitamin D above 80 nanograms increased again during 2002 to 11 without a corresponding increase in toxicity. So, no significant increase was found for the incidence of 25 hydroxy vitamin D levels even above 100 nanograms between the years 2002 and 2011 and without any clinical toxicity even at this level. So in this study, only one toxicity of hypercalcemia was found due to elevated 25 hydroxy vitamin D, and on finding 25 hydroxy vitamin D level was about 364 nanograms per ml. So even up to 100 plus, we are not having problems of hypercalcemia or stone. So, a significant positive trend from traditional 30 nanograms per ml in 2002 to 50 nanograms and 80 nanograms in 2011 over a period of 8 years. A positive trend, though insignificant, towards 100 nanogram per ml, and whether you increase it to 50 nanograms, 80 or 100 nanograms, there is no evidence of either hypercalcemia or stone formation. It was only one patient who showed an abnormal level of 364 nanograms. So, having said that, so the risk of toxicity and acceptable levels, as we can see, is definitely you can promote a monthly high dose vitamin D supplementation, but it does not increase the risk of kidney stone or serum calcium or PTH levels. So, over a period of 3.3 years, monthly supplementation with 1 lakh international vitamin D3 did not affect the incidence rate of kidney stones, hypercalcemia, and the final level of around 80 nanograms was found in patients after the end of 3.3 years. So, what we find is a lot of patients come to us, and when you prescribe a vitamin D or a capsule or something, they tell you, I am already taking, I have taken 8 days ka course. Then what did you do? 8 weeks ka course. What did you do? Oh, band kar diya. Doctor ne bhi diya tha. That also we stopped. So, we need to remember that we have to continue to supplement these doses to maintain levels at least 50 to 80 nanograms.
I would just interrupt here, ma'am, for this thing, for my inputs on this. So when you talk about hypercalcemia, you see a mild or a very mild or moderate condition of hypercalcemia that is also reversible. That is very important. Once you stop
Right.
the drug or once you stop the therapy, it is reversible. You get to back to the normal calcemia. and around a level of 100 is quite acceptable in the guidelines, be it your European guidelines, be it your American guidelines, or be it your Indian guidelines. So any guidelines shows that 100 nanogram is very acceptable, and also the clinical trials justifies that thing. So that is what my take is on that. Apart from that, I think hypercalcemia is not a very big issue in today's world to hear it out. So I think a daily therapy can be prescribed in this manner because it goes to a predictable rise, and also in the clinical trial, it has been justified that it doesn't cause any hypercalcemic event. So that's it from my side. I think, ma'am, you can go ahead and you can just give us the summary of this and what the take-home message can be. So that would be very great for the audience and for the learned people around.
Thank you, Dr. Hasnat. And to summarize all that we have been discussing, recent volumes of evidence were now shown, and it suggests that a level of 30 nanograms provides no better or minimal benefit over placebo in chronic disease conditions. So let's not be happy with levels that come up to 30 nanograms and then stop. In fact, we need to go above 30 nanograms to levels of 50 nanograms, which is proven beneficial in diabetes, polycystic ovarian disease, obesity, asthma, COPD, and depression, and above 80 nanograms for musculoskeletal disorders, autoimmune conditions, frailty in elderly people. Guidelines suggest that hypervitaminosis occurs above a level of 100 to 150 nanograms per ml, not below. Evidences highlight that severe hypercalcemia doesn't occur even at levels of 150 nanograms per ml, and that the best clinically proven superior manner of giving the vitamin D is in terms of an oral solution rather than giving capsules and intramuscular injections. Nanocarrier entrapped vitamin D3 given as 60,000 international units for 5, 7, and 10 days continuously have clinically proven to reach a level of 45, 51, and 96 nanograms per ml effectively. So do not be afraid of any toxicity conditions. And you have to counter the patients when they come and tell you, is this required to take such high levels? What is the benefit? And so we need to ensure that we tell them these are not toxic levels and you will feel much better clinically. Thank you. Dr. Mukhopadhyay.
Thank you. I think the bottom line for this is that, of course, we need to be aggressive in treating our patients for vitamin D. And as I said, it's a metabolic hormone. So you get a wide range of benefits from this molecule. And achieving and maintaining a particular level is very important. Do not be worried about toxicity. And in fact, it's not only me saying that. We have evidence for that. We have Dr. Horlick. In fact, I asked him, what about toxicity? The regimes which are recommended given orally, they do not cause toxicity unless the patient is advertently taken much higher doses. So I think this is important. We need to get them to a high level. So and maintain them. With the dose, you ideally would be needing some levels, vitamin D levels, to maintain them. You might maintain them with once a month or once in 2 weeks, but you need to get them to those levels and they will get benefit. Over to Dr. Debasis Basu.
Yeah. So last but not the least, the same, and harping and reiterating the fact that why are we so consciously aware of the fact that vitamin D is important, yet we do not really show that in our clinical practice. Why is it that we are hindering? Where is the obstacle? Where is the resistance coming from? Is it that once upon a time we were thinking about the fat soluble vitamins can cause toxicity in our medical school days? I would urge all of you here, I mean, including all my peer, brothers and sisters here, to read again Michael Hollick's that 2015, almost 10 years back, he published saying that vitamin D is not as toxic as once you thought. A historical and an up-to-date perspective. Read that. Be sure that it is not going to do any harm. If you don't inadvertently start, taking 10,000 international units every day, I'm saying 6 lakh every day for months and years, and you do not do a calcium monitoring and all that. which can really happen. But I mean, and we have seen vitamin D toxicity, yes, in infants with milk fortified. They had more than 2 lakh vitamin D exposure. Those were on record. So after that, he published this article, and I'm sure he kind of busted all the myths that around it. And it was 10 years back. So it's not 10 years ahead. And I think it's time that we change and we start behaving a little differently. And last, I would like to take this opportunity to offer my heartfelt and a very warm and a hot appreciation for all your presence, especially on a Sunday, afternoon, morning to afternoon. And
I don't know whether there are any questions from the
any
audience.
question?
I don't know, some people.
Because if you're not really hungry and if you're good enough, then we can go ahead. But I think it's been a long ordeal for all of us because of the technical snags and the hitches that came across. But as a moderator, given this chance, it was my honor to have all of you as guests in this wonderful program. I'm sure this is the first of the series, and we'll have more of these to come. And I'm again thankful for all your presence and the contribution of your presence that had added to the events, the refined event of academics that we had. Thank you. Thank you, everyone.
Thank you. Thank you.
Thank you, sir. So for your kind words and just summary, what I take from the take-home message is don't afraid for the hypercalcemia or hypovitaminosis thing. It is quite acceptable till a level of around 150, which has been proven by clinical studies. 100 has been already been approved in recommendation. And regarding how to get to that levels is via Nanocarrier and vitamin D for continuous supplementation, which has been shown superiority over any other formulation and any other weekly or monthly dosing. So that's it from my side. Just giving a vote of thanks to all the delegates out there, Dr. Debasis Basu for such a wonderful moderation and being a chairperson, Dr. Mukhopadhyay for his experience, and Dr. Cruz for, as usual, the enlightening us with her knowledge on this. I would also like to thank Mr. Samar Ghosh for his valuable inputs on the nanoscience part. Finally, not the least, OrthoTV for wonderful hosting the session. And that's it. And finally, going out with the thanking the audience for being such a wonderful audience. Being on a Sunday morning, as rightly said by Dr. Debashish, taking time out of that busy schedule and coming out. So it was a wonderful session. I think that's all for the conclusion part. So you have all been a great audience. That's all. Over to you, Ortho TV. Yeah, Ortho TV. Poonam?
Yes, sir.
Yeah. So I think it's all concluded here. So you can
Okay.
stop the recording.
Okay.
Okay. Chalo. Take care. Have a great weekend ahead.